the first thing you need to do is define resistance. Is it intolerance or is it a lack of efficacy? And then you have to look at what your expectations are. If your ultimate expectation is treatment-free remission, and someone doesn't achieve that, or they achieve a very stable response rate with a minimum of impact on their quality of life, their survival is equivalent to age-matched controls without CML. So that's not a reason to go start switching drugs. So number one's expectation. Remember, treatment-free remission is probably only going to be an option for about a quarter of all patients. The second thing is it intolerance? In which case you want to choose another drug that doesn't seem to have the same tolerance profile as the one you're having problems with. But before you've even done that, is what is the intolerance? Can you guide the patient in some way about how to take the drug? Maybe consider a co-medication, maybe improve the tolerance so you don't have to make a switch. It's terrible if you got a drug that's working extremely well on a patient, they've got good, deep responses, but they can't take because of a side effect. What is the side effect? How significant is it? Then the final one is whether it's efficacy. Have they not hit the primary milestone? The 3-month 10%, or you may have to move on something. Have they not gone beyond a 2 or 3 log reduction? You may have to move on something. What is resistance? Resistance means not having hit a plateau. Resistance is actually losing response. So in terms of that, the first thing you need to do is make sure that that is actually a loss of response, but also really work with patients about compliance. The biggest reason people lose response is compliance. It's probably 9 out of the first 10 reasons is a compliance issue. So you really need to work on it. So when you go from drug A to B to C, it's not the same set of reasons, excuse me, for all patients. And it also will depend on what is your sequence. For instance, if you fail the second generation drug used first line, you're not going to go back to a first generation drug. You may not go back to another second generation as your second line treatment. You may want to go into the third line drug for your second. So not everybody is saying it's the old story, one size does not fit all.